Thank you so much for inviting me and giving me the opportunity to talk a little bit about genetic epilepsies. In the surgical workup, I run the Neurogenetics Center here, and so this is something that's near and dear to my heart, obviously. I have no disclosures that are relevant, except for that even though I am an epileptologist, I'm not a surgical epileptologist, and so there may be some bias in this talk because of this. Sometimes when I talk about genetic epilepsies and genetic epilepsies in surgery, I sense a little bit of reluctance about possibly including genetic testing in the pre-surgical workup. There is often this very sort of dichotomized view of genetic epilepsies. On one side, the traditional genetic epilepsies, the channelopathies with, non-lesional MRIs that are probably may not be good candidates, at least for resective surgery. And then on the other hand, you have the focal structural genetic epilepsies that may be very good candidates. And then you have this gray zone where you don't really know what could testing, would that benefit? Should it be included? We've already planned our surgery. Could that mean we can't do surgery if it comes back positive? So I'll go a little bit through that in my talk today. So we'll be talking a little bit about genetics and epilepsy in general, and then review some of the studies that have come out that sort of review case series of surgical outcomes in genetic epilepsies, and then we can talk about whether this should be included into the pre-surgical workup. So my colleagues have seen this figure multiple times, but there has really been a paradigm shift in the etiology of epilepsy. And I think that even though the figure on the left is from 50 years ago, it's really happened, I think, over the past 10 or 15 years. So if you look at the circle, the gray circle on the left, 50 years ago, we knew that, 15-20% of epilepsies were acquired kind of across the board, and the rest was referred to as idiopathic. And so there's no such thing as idiopathic epilepsy, right? That term is a bit outdated now. So we think that epilepsy, the non-acquired epilepsies, by and large, are related to some changes in our DNA. And whether that is a monogenic change, so something that we can test for, really, or a more polygenic change, that really depends on the age of onset, on your risk, there are certain risk factors, and on the epilepsy syndrome, right? There are, so across the board, genetic generalized epilepsy is probably by and large polygenic, so the yield of, an epilepsy gene panel, whole exome sequencing is going to be low. Whereas some other syndromes, or let's say, non-acquired neonatal or infantile seizures, those are probably by and large monogenic. Somatic mutations may be picked up by epilepsy gene panels or whole exome sequencing. It really depends on the frequency of how prevalent, how high the degree of mosaicism is in the tissue that you're looking at, right? What is the clinical relevance of a positive, so a diagnostic genetic test result in epilepsy? And that's something that, we get asked all the time by families, by colleagues, by insurances who deny whatever test I wanted to order. And so some studies have started to look at this over the past years. So in their own cohorts, they found that in 40 to 70% a positive test result changed management recommendations. And that can be anything. That can be, we know that 10% of kids with this condition may have a cardiac malformation, so let's get an echo, right? They also saw that of those that were positive, it led to a change in anti-seizure medications, depending on the study, in 1 to 2/3 of patients. I think that's a little bit more than I see in my practice. But I think those numbers are really useful if you need to write a letter of medical necessity stating the clinical relevance for your genetic test. Other things that I think are extremely important, why to consider genetic testing. So it can obviously end the diagnostic odyssey. It allows for rare disease advocacy. It can reduce costs and stress for the family. It can help access services. It enables anticipatory guidance. And last but not least, and extremely important, it can help the family find a community, right? And that's what we always tell families, no matter how rare this condition is, there's almost always a family Facebook group out there somewhere. And that helps you find another family with a child with the same condition. And so when we meet with families, we give them all those resources. Another reason why you should consider genetic testing in epilepsy is because the guidelines say so. So about a year ago, a guideline for genetic testing in epilepsy was published and was endorsed by the American Epilepsy Society. And so the first recommendation that I marked here says, we strongly recommend that individuals with unexplained epilepsy be offered genetic testing without limitation of age. So when I first saw that, I was like, what is unexplained epilepsy? That's not a term that I commonly use, but fortunately they defined it. So they defined it as seizures not attributed to an acquired etiology such as trauma or infection. So, but what that means in return, that everyone with non-acquired epilepsy should be offered genetic testing per guidelines. The other questions, and I think we all know the answer to that one, is can structural epilepsies be genetic? Obviously, yes, they can. And how do we handle the non-structural genetic epilepsy? So we'll go through some of those series. Again, case numbers tend to be really small. So I don't think, I think a lot of it will have to be an individual case-based discussion, but I'll review some of the literature. So how likely is a positive test result in surgical cohorts? The first one is a study that was published in Europe last year of their cohort of, I think, 94 individuals with malformations of cortical development. Of their cohort, so they performed testing in 74 of them, and 18% had a positive genetic test result. Interestingly, so in their cohort, the post-surgical seizure freedom was significantly associated with complete resection of their lesion, but was not associated with the genetic test result, so that had no influence on their outcome. And then there were also publications from more mixed cohorts, and again, this is primarily looking at how high is the frequency of how likely is a positive genetic test result. So Sanders et al. Looked at a very large cohort, but also going back 3 decades. So 14% in their cohort underwent a genetic test, and 12% of this cohort actually had a positive result. And importantly, they excluded TSC and CRIT1. So CRIT1 is the most common genetic cause of familial cavernomatosis. So those two were excluded from that cohort. And then Erickson et al. Last year published their own cohort. And so in their cohort, 27% of their surgical cohort had a positive genetic test result that included CRIT1 and TSC, and the seizure freedom rate in their cohort was 25% after the procedure. So this is a study that I just saw cited on Dr. Koh's slide as well. So this is from the PERC Surgical Epilepsy SIG, published last year, and they looked at surgical outcomes in genetic epilepsies. And what I really liked about this is that they divided the groups. So they divided them into chromosomal aberrations, so copy number variants. Then there's a group of TSC, and I don't know if the pointer... Oh, okay. Can you see this? No. Okay. Doesn't seem to work the same as it looks here. Okay. There's a TSC group, then there is a structural genetic group that is not TSC, and then there are all the other ones. And so if you look at them sort of column by column in the chromosomal aberrations group, and again, the numbers are relatively small, in the chromosomal aberrations group, a small percentage, and this is any surgical procedure, right? Any of them. A small percentage, one patient became seizure-free, but the majority of them had significant improvement of their seizures with any procedure. TSC, as we know, there are these dual peaks often, right? You have the kids with really, really hard, difficult to treat seizures where a surgery may be a more palliative approach and they may have smaller improvements of their seizure frequency. And then you have the other group who may even become seizure-free or have very, very few seizures. And that's reflected here, I think, as well. And then there's the structural monogenic non-TSC group. So those are kids with mutations on the mTOR pathway, so other mTOR pathway genes. Those are tubulinopathies. They also included some of the somatic brain malformations in there. So they had Sturge-Weber in there and I think a hemi-meg case as well. And there you also have 50% that became seizure-free and another, 17% that had significant improvement of their seizure frequency. And then the other monogenic epilepsies are the kids with channelopathies, for example. Again, this is looking at all procedures. And again, you see that a very sizable proportion here had either a significant improvement of their seizures or became seizure-free. And so I thought that was really nice seeing this summarized like this. The next table is unfortunately really small. I'm sorry, I couldn't really get it any better way on there. I don't know if you can read it here, but essentially you have, so this time you have the chromosomal aberration kids, you have the structure monogenic, and this combines TSC and the other ones, and then you have the other monogenic, and they looked at what procedures were done. And so you can see the chromosomal aberration group, the majority of kids either had neuromodulation or a callosotomy done with, one kid receiving ablation and two kids getting a lobectomy. The similar for the other monogenic group, right? The channelopathies and other genetic epilepsies, the majority of those kids had either callosotomies or neuromodulation. Any other type of intervention was pretty rare in that group. And then, as expected, the structural monogenic group had every kind of intervention imaginable. So what was a little bit hidden in that paper, but what I thought was really interesting is that within the structural monogenic non-TSC group, there were 4 kids that had, genetically speaking, had a structural genetic epilepsy, but had a normal brain MRI. And so those 4 underwent a resection. They had focal epilepsy, underwent a resection. Actually, 3 out of the 4 were seizure-free after this. On the other hand, the kids with other forms of monogenic epilepsy, so the non-structural genetic epilepsies, from the kids that had a normal MRI, only 2 became seizure-free, and one of them had a callosotomy and the other one a hemispherectomy. And of the cohort with other monogenic epilepsy and an abnormal brain MRI, only 1 became seizure-free. Okay. If you look at single gene cohorts, and those are going to be the real small numbers that I mentioned before, I think it's going to be a while before we have larger numbers, also because there just aren't that many. If you look at one gene at a time, and especially obviously resective approaches, ablations are infrequently done, probably for a good reason. There were case series published in the past that non-lesional SCN1A has a really poor outcome with ablation or resection, even if it looks focal. There was a recent study that I thought was interesting. So they had 5 patients with SCN1A, and a lesion on MRI, and that they thought was the cause for the seizure. And even after performing lesionectomy, still 3 out of 5 didn't really have any improvement in their seizure frequency. On the other hand, PCDH19, which can look like SCN1A with clusters of febrile seizures, febrile status, they had a small case series of 3 kids, and only one of them had a visible MRI lesion. They performed a temporal lobectomy, and all of them became seizure-free. I think those numbers are too small to really draw conclusions, but I think this is something that, if you evaluate those patients in your surgical epilepsy clinic, those are maybe case reports to look at and to take into consideration. Enteropathies. So enteropathies are genetic epilepsies caused by mutations in genes in the mTOR pathway. So obviously TSC1, TSC2, DEPTEC5, and PRL2/3, mTORP10. So there was a recent case series, and that sort of corroborated what was reported in the PERC study. They excluded TSC because TSC again is its own field, but of the kids with structural genetic epilepsies caused by genes on the mTOR pathway, 2/3 of them became seizure-free after a resection, and that was independent of whether they had a visible lesion on MRI or not. So, should genetic testing be included into the pre-surgical workup? Just summarizing, so the other monogenic epilepsies, the channelopathies, yes, only a small percentage, or let's say a quarter or so, had limited seizure improvement, but the majority, 3/4, had significant seizure improvement with sort of the more palliative techniques. And so I think this sort of supports the case that Dr. Redondo and Dr. Dayat presented. I think it's really important to still evaluate them and evaluate all the available evidence, and then discuss what might be the best option for this, because they can really benefit, even if they may not be a candidate for a lesionectomy, but they can really benefit from other interventions. And then the other thing that I thought was really, really interesting, so if you have a patient with focal epilepsy and a normal MRI, if this patient ends up having a structural genetic epilepsy, that might actually increase his chances for a good outcome post-surgery. Summarizing, I do think that genetic testing should be included into the pre-surgical workup, and I think it should be seen as a puzzle piece, so one additional piece of information taken together with all the other studies that we do. I don't think it should be the one thing deciding of whether we do a procedure or not, but I think it's valuable information. How many surgical patients actually are receiving genetic testing? So the studies that I presented, the rates ranged from 9% in some to 80% in some others. And so I wanted to ask, so who thinks in their center 80 or more % of patients with non-acquired epilepsies undergo genetic testing? A few, okay. Yeah, I think we're getting there, right? We're getting there. We're working on it. Exactly. So, in which center is that really routinely integrated into the surgical epilepsy conference? So is that really part of the discussions? Yes. Okay, and so so who thinks this should maybe be integrated? Please raise your hands, because that's what I just talked about. Yes. Okay, and so how could you integrate this, right? And there are 2 things that we're currently doing at our center. I think it's really helpful if you have a template that everyone uses to prepare their presentation. And so if you add in a slide that says genetic test results, right after, I don't know, EEG, MRI, MEG, just add one. I think that could be really helpful. The other thing that we're doing is our current epilepsy fellow, Dr. Ramirez, has started a QI project. So she's assessing, or she's assessed sort of provider comfort levels with genetic testing in this field. And then for the coming 6 months, she'll discuss every patient's genetic testing or the lack thereof who's going to be presented in the epilepsy surgery conference, hoping that this will raise awareness and sort of also increase comfort levels for genetic testing. And yeah, that's it. Thank you.